So this screencast is just to provide a brief summary and overview of the pharmacological treatment of bipolar affective disorder during pregnancy. As we know, pregnancy does not protect against mood instability, and indeed, women with pre-existing diagnoses of bipolar affective disorder are at increased risk for postpartum relapse. According to a recent meta-analysis by Westlew and colleagues in 2015, up to 1/3 of females with a previous diagnosis of bipolar affective disorder will experience postpartum relapse. Perhaps one of the most remarkable findings of this meta-analysis was that the relapse rate was significantly lower in women who continued prophylactic medication as compared to those who stopped medication during the pregnancy, i.e. 23% versus 66%. Considering the implications that a relapse of a mood episode can have on both the mother and the infant, it then becomes important to consider what medications we may prescribe to these patients to prevent mood relapses postpartum. And of course, to keep in mind is the risk of teratogenicity. Any medication taken during pregnancy has the potential to affect the fetus, and the risks of teratogenicity must be carefully weighed against the risk of the untreated bipolar disorder to the mother and the fetus. Now, we turn first to valproate, particularly because it is one of the mood stabilizers that is most advised to be avoided in pregnancy, particularly in the first trimester. It carries the highest risk of teratogenicity of all mood stabilizers. Its malformation rate is approximately 10%. That's 10% of all fetuses exposed to valproate in utero will have malformations. These malformations can include neural tube defects, which make up approximately 5% of this total 10% rate, as well as spina bifida, atrial septal defect, cleft palate, hypospadias, and polydactyly. Perhaps more concerning is recent studies that have found that developmental deficits can be found in the newborns and up to the age of 4 years old in up to 70% of children who were exposed to valproate in utero. Another consideration is that valproate may cause vitamin K deficiency, resulting in coagulopathy of the newborn. If it is absolutely necessary, that is, if a female has demonstrated that she is unable to remain well unless on valproate, it is advised to minimize the doses to a maximum of less 1,000 milligrams per day in 3 or more divided doses, and to also monitor for neural tube defect by obtaining an amniotic alpha-fetoprotein at week 16 and an ultrasound at week 30. Less is known about lamotrigine. It is known to cross the placenta, and it is associated with a 3.2 risk of malformations. It has also been demonstrated that the risk is increased with doses over 200 milligrams per day. The primary malformation found in infants exposed to lamotrigine in utero is cleft lip and palate. Despite this increased risk, lamotrigine is considered a reasonable option for maintenance in pregnant women with a history of bipolar affective disorder. For the atypical antipsychotics, there is no evidence that atypical antipsychotics are associated with teratogenicity, but more controlled studies are needed to establish safety. When considering atypical antipsychotics, it may be worthwhile considering that quetiapine has the lowest rate of crossing the placenta at 24%, while olanzapine has the highest at 72%. There have been some changes in perinatal behavior observed in fetuses or newborns exposed to atypical antipsychotics, such as behavioral irritability, tremor, hyperreflexia, and impaired feeding. These appear to resolve shortly after delivery. It's also important to keep in mind that the combination of the known metabolic effects of the atypical antipsychotics can have a synergistic effect with the effects of pregnancy, thus increasing some females' risk for gestational diabetes. As such, metabolic monitoring is increasingly important in this population. Carbamazepine is very similar to valproate in terms of its indications in pregnancy. It also is to be avoided, especially in the first trimester. It has a lower malformation rate of valproate, with spina bifida rates of 1%, and developmental delay seen in only up to 20% of children exposed to valproate in utero. It's also been associated with congenital heart defects, craniofacial defects, and fingernail hyperplasia. As well, similarly to valproate, it can cause vitamin K deficiency, which results in coagulopathy in the newborn. And similar to valproate, if absolutely necessary, to use carbamazepine for mood stabilization prophylaxis, obtain an amniotic alpha-fetoprotein analysis at week 16 and ultrasound at week 30. Finally, lithium. Although the overall recommendation is to avoid lithium in pregnancy, especially in the first trimester, given its malformation rate of 8%, the general consensus is that lithium is an appropriate maintenance treatment for pregnant women with a history of bipolar affective disorder. The primary anomaly associated with lithium is Epstein's anomaly at a rate of 0.1%, which is 5 times the rate in the general population. In significant contrast to valproate and carbamazepine, there is no long-term neurobehavioral sequelae of exposure to lithium in utero. It has, however, been associated with perinatal hypotonia, poor feeding, goiter, and both oligo and polyhydramnios. These issues tend to resolve shortly after delivery. Because lithium is considered a safe and effective mode of treatment for management of bipolar affective disorder in the pregnant patient, keeping in mind the teratogenic risks that are associated with it, there are some guidelines for its use. First and foremost, maternal lithium levels must be monitored carefully, particularly in the third trimester, as fluid shifts do occur in the pregnant female at that time. Additionally, like all lithium use, it is advised to avoid the use of agents that increase lithium levels, such as NSAIDs, but also to avoid sodium-restricted diets that may have been tried to limit edema, but will also cause an increase in lithium. It's also important to be aware of any factors that can influence fluids and hydration in pregnancy, such as hyperemesis gravidarum, preeclampsia, or loss of fluids at delivery. It is also important to monitor for any fetal renal abnormalities, the aforementioned oligo and polyhydramnios. And finally, it is worth considering discontinuation of lithium at the onset of spontaneous delivery or induction of labor, and to resume at the preconception dose, not the dose that the woman was on immediately prior to delivery, as that was adjusted to her her increased fluid weight, as soon as the mother is stabilized post-delivery. So overall recommendations for management of bipolar affective disorder in females who become pregnant. For individuals who have had long periods of pre-pregnancy euthymia, you may attempt a slow, i.e. over 2 to 4 weeks taper to avoid medications in the first trimester, which is of course the period associated with the highest rate of teratogenicity. It is important to note here that faster taper rates are associated with higher rates of relapse. For individuals who have histories of instability when they're not on medications, medication is recommended, and lithium is preferred over carbamazepine and valproate because of its lower teratogenicity. Atypical antipsychotics may also be used with the caution that there is limited evidence. And finally, all mood stabilizers carry some teratogenic and peripartum toxicity risk, so the choice of treatment should be made on a case-by-case basis, considering the safest regimen to maintain maternal mood and fetal health. Thank you.